Good evening, dear colleagues. As previous presenters, I also would like to um, say that atherosclerosis is one of the causes of ischemic stroke. Maybe the leading, but not the only cause. There are three major treatment or prevention modality, like medication, um, but that's not the topic of our discussion today. We're going to discuss pros and cons of surgical and endovascular interventions. Carotid artery stenting is a very intensively studied treatment modality. The goal of both, actually, prevention of brain stroke due to occlusion of the extra intracranial vessels. Advantages and limitations of CS. Well, minimal invasiveness and minimal operative injury, minimal blood loss, lack of general anesthesia. So stenting is done by highly qualified cardiologist staff personnel in order to detect cardiac complications and their correction. Uh, um, uh, um, Reduced hospital length of stay. Well, it's more important for the European countries where the cost of hospitalization is much higher. However, it's becoming important even in Russia. I mean, after stenting CS, a patient may be discharged next day. So, like a better patient comfort. And very few people ask patients what the patient would prefer if it's at discretion of the patient. If the patient is allowed choosing. I believe that the majority of patients with comparable risks of stroke and restenosis, I believe that the majority of patients would choose stenting. Limitations. It's somewhat difficult to assure adequate regimen of anticoagulation disaggregation in case of combination intervention, and a risk of unstable hemodynamic like bradycardia and prolonged hypotension due to the stent dilation after its implantation. So we prevent bradycardia with atropine, and actually we encounter this complication rather rarely. High surgical risk may be viewed as relative indications for stenting of internal carotid artery. Well, there are some other contraindications like concurrent diseases, age over 80. As for anatomical peculiarities, the contralateral occlusion of the internal carotid artery, contralateral paralysis of the nervus laryngeus, conditions after neck irradiation, a high position of bifurcation that may become a problem for surgeons. Relative contraindications for stenting. Patients with problematic arterial access, patients with complicated anatomy of the brachiocephalic arteries, patients with twisted and calcified arteries, patients with massive fresh thrombi. The three types of the aortic arch. In fact, instead of femoral access, we can use brachial access. Well, that's twisted, common carotid artery. It again a significant pros for carotid and arterectomy. Those are the two axes, even in case of bovine arch. About 90% of patients with impaired internal carotid artery may undergo either stenting or endarterectomy. Well, oftentimes when coronary arteries are impaired, we resort to stenting. To conclude, I would like to say that stenting of the internal carotid artery may be performed in majority of patients with critical symptoms of the carotid artery stenosis. Stenting is less traumatic intervention compared to endarterectomy. Stenting in patients with high surgical risk is an alternative to surgical intervention that allows a reduction of the hospital complications rate. Stenting as well as endarterectomy, depending on like surgical hands, shows very low perioperative complication rate. Thank you for your attention.